afternoon. I'm Dr. Caldis. I'm joined by Dr. Horner and Dr. Chiu, and I'd like to welcome y'all to the afternoon session, Future of Stroke Recovery. And we have some really exciting information for you this afternoon that I think will fall in line with what you've seen all day. It's been a great conference so far, and this one will not disappoint. I'd like to introduce our first speaker, Dr. David Chiu, a man who needs no introduction and has participated in almost every major trial that has put stroke and stroke treatment on the map. He currently serves as the Elizabeth Blanton Waring Chair of the Eddie Skurlock Stroke Center, Professor of Neurology at Weill Cornell, and Principal Investigator of the TRIPS-MS trial. Dr. Chiu, it's a great pleasure having you here today.
Thank you very much, Teresa. The first human clinical studies of transcranial magnetic stimulation for stroke recovery began almost 20 years ago. And it was based on the idea, the principle, that functional recovery after stroke is based on neuroplasticity, which is the reorganization of brain connectivity. And it was thought, even 20 years ago, that magnetic brain stimulation was one of the most promising modalities for potentially restoring motor function after stroke through neuroplastic changes in brain organization. Previous clinical studies of magnetic brain stimulation have generally evaluated single site stimulation involving either high frequency excitatory stimulation of the ipsilesional cortex, the ipsilesional hemisphere, or low frequency inhibitory stimulation of the contralateral side. However, a recent large multicenter randomized clinical trial of single site brain stimulation yielded negative results. I'm going to be introducing the novel transcranial rotating permanent magnet stimulator, also dubbed TRIP-MS. This is a study that we reported, our investigators at Houston Methodist Hospital, initially a year ago at the International Stroke Conference, and you can also see the subsequent publication that we have. TRIP-MS affords multifocal, simultaneous, bihemispheric stimulation of the brain using a non-invasive, portable, wearable, battery-operated device that provides prolonged oscillatory pulses of stimulation that are unaffected by head movement and indistinguishable from sham. This is a picture of the device. TRIP-MS was invented by Dr. Santosh Helekar here at Houston Methodist Hospital, along with his physicist collaborator at Cornell, Dr. Henning Voss. And as you can see, this device looks like a modified diving cap or swim cap to which is affixed multiple stimulators on both sides of the brain, driven by a controller box which can be operated off a smartphone app. We conducted at Houston Methodist Hospital a first-in-humans, phase 1/2A, single-center, randomized, double-blind, sham-controlled clinical trial to evaluate the safety of TRIP-MS treatment, to assess the restorative reorganization of brain function, and to study the recovery of motor function. We had 30 planned subjects, all of whom had chronic ischemic stroke of at least 3 months duration, with persistent stable hemiparesis involving at least the upper extremity, age 18 to 80. Subjects who were excluded were patients who had a history of seizure or who had on their screening baseline EEG epileptogenic activity, or who had any active unstable medical condition, any reason that they couldn't undergo functional MRI, or use of Botox for post-stroke spasticity within 2 months of enrollment. Our protocol involved 40 minutes of magnetic brain stimulation per session for 5 sessions per week for 4-week duration, so a total of 20 sessions. The cap was fitted with 6 microstimulators, 4 on the side of the stroke, of the lesional infarct, and 2 on the opposite side. On the lesional hemisphere, a pair of the microstimulators were placed flanking the stroke lesion if it was a cortical infarct. And in the case of a subcortical stroke, these 2 microstimulators were placed directly on top of the primary motor cortex 3 centimeters apart. A third microstimulator was placed opposing the lateral premotor cortex, and the final one on the supplementary motor cortex. And on the contralesional hemisphere, a pair of microstimulators were placed 3 centimeters apart on the primary motor cortex. This pair would deliver inhibitory low-frequency stimulation. The primary safety outcome of our study was the incidence of adverse events. The primary efficacy endpoint was the change in the ipsilesional hemisphere active voxel number on task-based bold fMRI after the end of treatment in active compared to sham-treated patients. The secondary efficacy endpoints were 6 clinical scales of motor function, namely the Fugl-Meyer motor arm score, the Action Research Arm Test, the grip strength on the affected side as measured by a dynamometer, pinch strength on a dynamometer gauge, the gait velocity on the timed up and go test, and the NIH stroke scale. We ended up randomizing 31 subjects because one patient had to withdraw after only 2 days of treatment. She was unable to get transportation to return to the clinic after that. And one other patient had to be excluded from the efficacy analysis because his fMRIs were uninterpretable. However, his data was included in the safety analysis. Of the 29 total patients who completed treatment and could be evaluated in the efficacy analysis, 14 had been randomized to active TRIP-MS, and 15 had been randomized to sham treatment. The baseline subject characteristics included a median age of 66. There was about an even split between men and women. The lesional side was the left hemisphere in 59% of the subjects, and cortical strokes represented 45% of our study population. The stroke chronicity ranged anywhere from 4 months all the way up to 16 years. And the 2 treatment arms did not significantly differ in any of these baseline characteristics. Here are the results of our safety endpoint of the study, the incidence of adverse events. As you can see, in the active treatment group, there were 2 subjects that experienced a total of 5 adverse events, 3 of which met criteria for serious AEs. In the sham treatment group, 5 subjects suffered 6 AEs, 2 of which were deemed to be serious AEs. You can see that there was, on the prior slide, 1 subject in our active TRIP-MS group who contributed multiple adverse events, including a recurrent stroke. This was a patient who had known severe intracranial middle cerebral artery stenosis, which was felt to have been the cause of his original index stroke. All AEs were judged to be unrelated to treatment, and TRIP-MS was found overall to be safe and well tolerated without any clear device-related adverse effects. Now we will discuss the primary efficacy endpoint of our trial, the number of active voxels in the ipsilesional hemisphere on a bold fMRI. For our primary efficacy endpoint of the trial, we found that there was statistically a significantly greater increase immediately following active TRIP-MS compared to sham. This significant difference was maintained on the repeat fMRI 1 month later. And as a result, we found statistically a significantly greater active voxel number immediately after active treatment compared to sham, a median of 227 active voxels compared to 26. That's a overall 8 to 9-fold difference between the treatment arms. And correspondingly, we observed a significantly higher proportion of subjects, of patients who experienced at least a 15% increase in the active voxel number immediately after active treatment compared to sham, 64% versus 20%. These are the same results that we just went over in a table form. You see the first column showing the active treatment group, the second column, sham treatment, and then the significant p-values highlighted in red. There are other important fMRI outcomes, and one of them is the mean intensity of the active voxels on bold fMRI. For this particular parameter, we also observed a statistically significantly greater increase following active tryptase treatment compared to sham. And as a result, a significantly higher mean intensity of active voxels immediately after treatment compared to sham. And correspondingly, there was once again a significantly higher proportion of subjects that showed an increase in mean intensity of active voxels after treatment compared to sham, 71% versus 20%. In a post hoc analysis, we found that in our overall study database, the mean intensity of active voxels was statistically significantly correlated to the results of 5 of the 6 clinical scales of motor function, meaning that fMRI is a clinically relevant and meaningful marker of stroke recovery of motor function. These are the results that we just discussed, again in a tabular form with the significant p-values shown there in red. So we often will say that a picture or an image says 1,000 words. So for the next 3 slides, I'm going to be showing you representational fMRI scans of 3 of our trial subjects. The first 2 patients undergoing active tryptase therapy, and then third set of scans will be for a sham-treated subject. So this is our first active group subject who had a chronic left hemispheric ischemic stroke. You see in the left-hand panel the bold fMRI activity pre-treatment, and then in the middle panel the immediate or day 1 post-treatment fMRI, and then in the right-hand panel the repeat functional MRI 30 days later. So what you can see here is immediately after treatment an obvious increase in physiological bold activity. Bold is the blood oxygen level dependent physiological activity. You see an increase there in the ipsilesional hemisphere, which is, if anything, further augmented in the repeat scan 30 days later. This is another subject, a second subject in our tryptase trial in the active treatment arm. And once again, you see a dramatic increase in the physiological activity in the ipsilesional hemisphere, the bold activity immediately after treatment, which is sustained 30 days later. This is direct evidence of neuroplastic changes, functional reorganization of brain connectivity after tryptase. We saw none of these dramatic changes in the ipsilesional hemisphere in any of our sham-treated patients. And this is such a patient. This is just one of our sham-treated patients we selected here so that we could compare apples to apples. Another patient with a chronic left hemispheric ischemic stroke, but you don't see the increase in bold activity after sham treatment. We're now going to turn our attention to the secondary efficacy endpoints. And I'll remind you that these were the 6 clinical scales of motor function. Now, these were secondary rather than primary efficacy endpoints because this was a first-in-humans phase 1/2A clinical trial involving only 30 patients. So you don't expect to have your lead-off hitter hit a grand slam. You're not expecting to see positive results on clinical scales of motor function with your first clinical trial involving only 30 subjects. Therefore, we wanted to use the fMRI as the primary efficacy endpoint. But it would be nice, of course, to see some signal of benefit on clinical outcomes. And what we did see was, in fact, a significant increase in the gait velocity on the timed up and go test after active TRPMS therapy. Gait velocity was one of the 6 clinical scales of motor function. We observed a numerical improvement, albeit non-significant improvement, in 4 of the 5 other clinical scales of motor function: the Fugl-Meyer, the ARAT, the grip strength, and the Endpoint stroke scale. There was no improvement observed in the 6th scale, clinical scale of motor function, the pinch strength. In the 5 scales where we did see numerical improvement, this improvement persisted over the 3-month follow-up period, including a significant increase in the gait speed on the timed up and go test. And I'm showing you here some bar graphs of the 6 clinical motor scales. And for those of you who are not familiar with all of them, with the exception of the Endpoint stroke scale, it's better to have a higher score for all of these. For the Endpoint stroke scale, as you well know, a lower scale is better in terms of neurological outcome. And you see the p-values there represented, which designate the change compared to the baseline pretreatment median. This slide expands the axis for the Fugl-Meyer motor arm score. And the Fugl-Meyer is often in the rehab world considered as a first among equals for the neuro rehab scales of motor function. And what you see shown here in the first bar is the pre-treatment baseline median of the Fugl-Meyer motor arm score, and then the 4 subsequent bars are different time points after the end of treatment from day 1 to day 90. And you see the p-values for the comparisons compared to the pre-treatment baseline. To give you a perspective on these changes, the validated minimum clinically important difference or change in the Fugl-Meyer motor score is 4.25 points. So anything over 4.25 points could be said to be clinically meaningful and significant. And this is the expanded view of the gait speed on the timed up and go test. For the gait velocity, as I mentioned, there was a statistically significant increase compared to baseline in the active TRPMS group for each of the time points after the end of treatment. However, when comparing the active and the sham treatment groups, none of these clinical endpoints showed statistically significant difference. Of course, we need to have a larger clinical trial to demonstrate that. So to conclude, this study was the first bilateral, multifocal, transcranial, rotating permanent magnet stimulation trial in a chronic stroke patient population using a novel wearable device. We found that TRPMS was safe and well tolerated. We proved that TRPMS induced significant functional cortical activation in the injured brain, as demonstrated by fMRI. The clinical scales suggested possible improvement of motor function, which persisted for 3 months after treatment. And furthermore, the treatment effect on the primary efficacy endpoint was not significantly influenced by age, the stroke chronicity, or the cortical versus subcortical infarct location. The implications of this is that we surprisingly, impressively, had a positive trial for its primary efficacy endpoint. The improvement of the clinical motor function that is suggested in this trial will need, of course, to be verified in a larger scale, multi-center randomized clinical trial. And I'm pleased to say that the sponsor, the technology owner currently of TRPMS, which is Soraya Medical, has pledged to sponsor such a multi-center trial. Of course, it's been a little bit of a challenge in the last few months to launch a large trial like this in the face of a pandemic, but we're very excited about that, and we're endeavoring here at Houston Methodist Hospital to do nothing less than to discover the first proven effective treatment for stroke recovery in patients with chronic stroke. So I thank you very much for your attention in this topic, and Teresa, I throw it back to you.
Yeah, well, thank you, Dr. Chiu. That was really exciting. And boy, you spoke right to my heart as a rehab doctor. with that chronic stroke. It's an area that we struggle with, what to do and what to offer. And of course, we look after these patients lifelong, and they come to us, and at the annual visit or semi-annual is, what do you have available? What's out there now? Is there anything? So this is incredibly exciting. Do you see, since it's portable and wearable, that eventually it would be something that a stroke patient would have at home, and they would have some sort of booster treatment or dosing or some sort of long-term treatment, or it would be a shorter-term treatment?
That's a very tantalizing, thought, isn't it, Teresa? Because I'm a clinical trialist, and for a study like this, I focus on obviously the safety and the efficacy, and I want to make sure that patients, get the therapy according to a protocol, and that we set to it very rigidly.
Right.
So we mandated in this clinical trial that patients come in for their 20 sessions, sit for 40 minutes, get this, monitored by our research coordinators and so on. But the tantalizing part of this technology is indeed that it is portable and wearable. It's not the fixed huge coils that have to be stationed in the hospital or in the clinic. It's something that patients actually could take home. And so I think after a little bit of validation that patients can do this appropriately and safely at home, this would be a very, very tantalizing way of potentially, as you said, maybe even extending the treatment beyond the 20 sessions. Patients could perhaps get a booster treatment if they felt that their motor recovery was flagging. I mean, these are all things that we can explore.
Or that you augment it more, right?
Absolutely.
I mean, because once you reach a new point, then you can reach a new point, right? This is the exciting part about motor recovery is, we look after folks that we didn't think to get to a milestone, and when they do, then wow, they can go to the next milestone, and you may have a treatment that can help us there.
Exactly right.
All right. Well, thank you very much. We appreciate you joining us. We are very blessed to have Dr. Chiu with us and leading the way with us for stroke and stroke trials. Thank you, Dr. Chiu.